Welcome, everyone. Please take a seat. There's still some seats in the front for those standing in the back. Okay. Hello, everyone. My name is Pierre Del Moral. I'm the Associate Director of Marketing for Oncology Testing at Illumina. We're thrilled to have you today for this series of workshops. We have two workshops back-to-back. At Illumina, we're really passionate about increasing the adoption of NGS into clinical oncology practice. And as such, we have two workshops today, one mainly focusing on liquid biopsy use in oncology testing, the other one on tissue biopsy. And as such, I just wanted to introduce our speaker today for our comprehensive genomic profiling talk with the use of liquid biopsy samples, and specifically focusing on the clinical utility in clinical community practice and academic practices. And the speaker today is Dr. Alison Roos, our Associate Director of Medical Affairs. Alison, welcome.
Thank you, Pierre, and I want to echo what Pierre said, and thank you all for joining us today. So for today's talk, I want to start with a background on comprehensive genomic profiling, and then we're going to cover tissue and liquid-based CGP and really dive into the pros and cons of the different approaches for biomarker testing. And finally, I'm going to end with the clinical application and discuss some real-world data on how liquid and tissue biopsy can be utilized for clinical decision-making for patients with treatment-naive advanced non-small cell lung cancer. To start with some background, precision medicine really is identifying the right treatment for the right patient at the right time to maximize outcomes for patients with advanced cancer. And so if we taking advantage of novel technologies and clinical advances over the past 2 decades, precision oncology leverages tumor-specific biomarkers with either approved or available targeted therapies. So if we look at some landmark studies that really have demonstrated successful implementation of a precision oncology approach, these include imatinib for BCR-ABL CML, vemurafenib for BRAF melanoma, and a seminal approval in 2015 for pembrolizumab for patients with tumors that were microsatellite instability high or mismatch rare deficient. And this really was a pivotal movement in precision oncology because it represented the first tumor-agnostic approval such that any patient with a tumor that was microsatellite instability high was eligible for pembrolizumab. So to date, there are 90 FDA-approved targeted therapies for eligible patients, and a recent report demonstrated that over 50% of clinical trials now include biomarker testing. So this field is rapidly evolving. If we take a look at the number of tumor-specific biomarkers across different tumor types, what you can see is that these are growing substantially. And what we know about these actionable biomarkers is that patients that receive targeted therapies have improved outcomes. Additionally, there are now 5 FDA-approved tumor-agnostic biomarkers, such that any tumor that harbors a BRAF mutation, an NTRK123, or RET rearrangement, is tumor mutational burden high, defined as greater than or equal to 10 mutations per megabase, or microsatellite instability high, will be eligible for a targeted therapy. Paramount to the success of these targeted agents is in the growing portfolio of targeted therapy options for patients with advanced cancers is the ability to identify patients with tumors that harbor these genomic biomarkers. And as the number of tumor-specific and tumor-agnostic biomarkers continues to expand, there is a need for broad genomic profiling to be able to identify these patients. And this is being performed using next-generation sequencing, which is increasingly being substituted for conventional approaches such as single marker testing. So one next-generation sequencing approach is comprehensive genomic profiling, or CGP. CGP analyzes hundreds of genes many included in guidelines or in clinical trials, to maximize therapeutic options for patients. CGP analyzes both single gene mutations and the different types of alterations that can be found in these genes, such as SNVs and indels, novel and known fusions, and I think it's important to recognize being able to identify fusions due to the efficacy of the newer approved agents for patients that harbor actionable fusions, including copy number alterations. In addition, comprehensive genomic profiling can also report out tumor mutational burden status and microsatellite instability, which are both biomarkers for immunotherapy. Additionally, some assays also report out genomic instability, either through HRD or LOH. So the goal of comprehensive genomic profiling is to ensure appropriate biomarker testing to maximize treatment options for patients with cancer. And numerous studies have demonstrated the benefit of using a comprehensive genomic profiling approach. So if we look at a recent study which looked at the utility of different testing modalities in a large community network in the United States, this demonstrated that CGP may avoid potentially missed treatment options for patients with newly diagnosed patients with non-small cell lung cancer. So in this study, they looked at patients that either had non-NGS testing, NGS testing that was not CGP, or patients that had CGP testing. And they found two important things. One, the frequency of unsuccessful testing was lower in patients that had NGS testing, including CGP, compared to non-NGS testing. And this is critically important for patients with non-small cell lung cancer, where you need these results prior to first-line therapy. Additionally, what's shown in the graph here is that patients who had CGP testing had the lowest missed targeted therapy options, showing that CGP really maximizes the therapeutic benefits for patients with cancer. Additional studies have demonstrated the benefit of CGP approach across multiple different tumor types, including CGP can identify more patients with BRAF alterations in melanoma, in colorectal cancer, identifying more patients with KRAS mutations that would confer resistance to anti-EGFR therapy, as well as identifying more patients with non-small cell lung cancer that have ALK or EGFR alterations. So taken together, comprehensive genomic profiling, by providing comprehensive and accurate information on the genomics in a tumor, can provide multiple pieces of information. One, it can identify patients who would benefit from a targeted therapy through revealing actionable biomarkers in their tumors. Two, it can inform patients that may benefit from immunotherapy, including by looking at tumor mutational burden and microsatellite status, as well as providing critical pieces of information about negative predictive biomarkers, such as in lung cancer, where we know patients that harbor actionable oncogenic drivers do not respond as well to single-agent immunotherapy. It can provide information about patients that may benefit from clinical or be eligible for clinical trials through the broad interrogation of biomarkers. And finally, it could provide information whether a precision approach is not the right treatment for a patient, and this provides patients a peace of mind that all options have been explored. The problem is that precision medicine approaches aren't being used as broadly in patients with cancer, and there's many barriers into incorporation of a predictive biomarker testing in patients with advanced cancer. And among other barriers to incorporation of this approach includes tissue insufficiency, either to quality or quantity insufficient. And this has been observed in up to 30% of the time in patients with advanced non-small cell lung cancer and prostate cancer, two indications where biomarker testing is critically important for targeted therapy selection. Up to 25% of the time in biliary tract cancers, including cholangiocarcinoma. We know that cholangiocarcinoma is a very molecularly heterogeneous disease where biomarker testing is becoming more and more integrated into standard workup. And finally, 20% of the time in other advanced cancers. So tissue insufficiency is a major barrier to incorporating a precision medicine approach. So there's a need for other analytes for getting that biomarker information for patients with advanced cancer. So liquid biopsy is a broad term that incorporates analyzing different genomic information from fluids in patients with cancer, including blood, CSF, urine. However, the most commonly studied is plasma circulating free DNA from patients with cancer. So cell-free DNA are small fragments of DNA that are released during apoptosis or necrosis. And one small component of the cell-free DNA in patients with cancer is circulating tumor DNA. So these are tumor-derived fragments of DNA that comes from apoptosis or necrosis of the tumor, and that's shed into the peripheral blood. And this can come from both the primary site and the metastatic site in patients with cancer. Circulating tumor DNA is an attractive biomarker. Due to the half-life, it's thought to be a real-time biomarker with multiple clinical applications across the cancer continuum due to the dynamic half-life of these DNA fragments. ctDNA shedding levels vary. We're going to go into the factors that can impact ctDNA shedding. And it really is only a small portion of the DNA that's in cell-free DNA. And I think that's an important concept to understand when thinking about liquid biopsies. So both circulating tumor DNA and then DNA and RNA extracted from tumor tissue can be used for comprehensive genomic profiling for biomarker testing. And there's advantages and limitations to both approaches. So tumor tissue is the established reference standard for biomarker testing. So there's a few advantages, and these are just a couple that I list here. One is you can get pathology information, right? You know the amount of tumor that's in the specimen that you're performing sequencing on. You get that important PD-L1 assessment that you can only get from tumor tissue. It has high sensitivity and specificity for biomarker analysis. And so it really has been the most used analyte for biomarker testing. However, there are innate limitations to tumor tissue, mainly stemming from the biopsy procedure itself. It's invasive. Some tumors have very in difficult locations to biopsy. Some patients present with bone-only METs, which you either have to go through decalcification or very specialized protocols to be able to perform next-generation sequencing on. So there are limitations to getting the specimen itself. Additionally, it represents a snapshot of the tumor genomics. It doesn't represent the heterogeneity found within the tumor, and this is increasingly important for patients progressing on a targeted therapy. There is a longer turnaround time. Logistically, this is a longer process compared to using a liquid biopsy approach. And additionally, re-biopsy is not always feasible in instances where the upfront biopsy or previous tissue is insufficient for analyses. ctDNA represents an alternative to tumor tissue. So this is less invasive, right? It's a quick blood draw. There's easy serial testing, so for some applications in cancer, this is really attractive, the ability to do a quick blood draw and get a snapshot of the genomics over time. It more represents tumor heterogeneity. It's reflective of both the primary and the METs, so you get a global image of the genomics within that patient. And there's a faster turnaround time. It's logistically less burdensome to get results. There are limitations, though. And so one is clonal hematopoiesis of indeterminate potential. This is noise in a liquid biopsy that stems from non-tumor mutations that is a normal process during aging. I think where this has really come into play is with the approval of PARP inhibitors for prostate cancer. Some of the genes implicated for PARP inhibitor therapy are also implicated in CHIP. So this can make interpretation a bit more difficult for physicians when looking at these types of results. One innate limitation to all liquid biopsies is sensitivity is dependent upon tumor shed. And this is reflected in FDA labels for approved liquid biopsies that state in case of negative liquid biopsy result, tissue biopsy should be performed due to concerns over a false negative. And so shed rate is a really important concept when thinking about liquid biopsies. So what are some factors that impact circulating tumor DNA levels or shed rate in circulation and detection of alterations in circulating tumor DNA? So if we look across tumor types, what we find is that tumor type really matters when thinking about the amount of circulating tumor DNA in circulation. So this was a study that shown here that looked at the frequency of alterations detected in ctDNA, and you can see a wide variance across different tumor types. What we know is that ctDNA can be detected in non-CNS tumors, where there's major limitations is in patients with primary CNS tumors, where it's thought that maybe the blood-brain barrier is impeding release of the ctDNA into circulation. So that's maybe a place where plasma ctDNA might not be the best analyte for getting genomic information. Other factors that impact ctDNA levels include tumor burden. We know that more advanced stages of cancer have more ctDNA, they have more tumor burden compared to earlier stages where you might need a bit more sensitive assay to detect circulating tumor DNA. Timing of blood sampling is critical, and I think this is a factor that has really come into play the more that liquid biopsy has been used clinically. So for example, for a patient on active treatment, that's probably not the right time to draw, where this drawing should be done probably would be the best time would be before treatment. Disease status matters, so patients with stable disease have less ctDNA than progressive disease. More metabolic tumors and vascular tumors tend to shed a bit more ctDNA. And then the type of variant matters, and I think this is an important concept to consider. SNVs might be a bit easier to call, for example, with liquid biopsy, whereas certain copy number alterations, such as amplifications and especially losses, are a bit more difficult to call using a liquid biopsy in ctDNA. So as we continue to use liquid biopsies, we're realizing there's more and more clinical and pathological features that impact the amount of circulating tumor DNA in circulation. It's not as easy as just drawing whenever we want to get that genomic information. And I think one place where ctDNA testing could be a very powerful tool is in metastatic castration-resistant prostate cancer. So there's 2 approvals for PARP inhibitors for patients with metastatic castrate-resistant prostate cancer based on the presence of HRR mutations. The problem with these, with getting genomic information for these patients is that many present with bone-only mets, which is very difficult to get genomic information. So liquid biopsy is being explored actively in this area as a way to get genomic information. So a recent study looked at the clinical and pathologic features associated with ctDNA in patients that were treated during the course of their clinical care. So this was looking at multiple different variables and how they correlated with the amount of circulating tumor DNA or tumor fraction, shown here as TF. And so what they found, which corroborated previous studies, is that proxies of tumor burden, most notably PSA, it correlated and impacted the amount of circulating tumor DNA in circulation or tumor fraction. And so this is really important to think about when we think about when to use liquid biopsy for these patients. One can imagine a time where we can use some of these clinical and pathologic features to help guide physicians on when to draw and when to use liquid biopsy, perhaps instead of tissue-based testing. And so as more and more data comes out, we're anticipating more features that might correlate with ctDNA burden and can help shape this field a bit better. So there's multiple applications of ctDNA testing across the cancer continuum. It's being explored as a biomarker for patients with early stage disease to detect MRD. It's being most actively being explored in colorectal cancer for risk stratification, determining whether or not you can escalate or de-escalate therapy based on whether or not there's detectable ctDNA, to monitor response to adjuvant chemotherapy. This is a space where the assays need to be a bit more sensitive compared to maybe an advanced stage disease. In advanced stage disease, ctDNA is being used to determine treatment selection. So in instances where tissue is insufficient and in other tumor types, maybe upfront as an option to get that biomarker testing information. And then to monitor treatment response. So upon progression, because it can reflect the heterogeneity of the tumor a bit better, using liquid biopsies and ctDNA testing to determine what are those treatment resistance mechanisms and are they actionable for future treatment decisions. So what I want to focus the rest of this talk on is the use of liquid biopsy for treatment selection, and really focusing on a non-small cell lung cancer and determining the biomarker testing in patients with treatment-naive advanced non-small cell lung cancer. So non-small cell lung cancer really is the poster child for a precision medicine approach. There are multiple FDA-approved therapies for biomarker-driven non-small cell lung cancer. What we show here in this timeline is the approval of multiple agents over time. And what I think you can appreciate is that there's an increasing availability of first-line oncogene-targeted therapies for patients with advanced non-small cell lung cancer. So these therapies have the best efficacy for first-line treatment. And so you can see the emergence of these therapies over time. So current professional guidelines recommend biomarker testing upon initial diagnosis of advanced or metastatic non-small cell lung cancer. Guidelines recommend using broad molecular testing that covers over 10 genes now. This field is rapidly evolving, and there's more biomarkers in non-small cell lung cancer than have been previously. In addition, they also recommend doing PD-L1 immunohistochemistry. So this is a very simplistic view of a decision-making tree. So if a patient has a targeted therapy due to the efficacy of targeted therapies in the disease, they should or they have a targetable alteration, they should receive a targeted therapy. If there's no targetable alteration, the decision depends really on PD-L1 status and the patient's clinical factors. So there's multiple decisions that go into play. However, there's a few points I want to make here. It's really critical to get molecular results back prior to first-line therapy in patients with treatment-naive non-small cell lung cancer. The first reason is, one, there's multiple targeted therapies available in the first-line setting, and they have the best efficacy when used upfront compared to in later lines of therapy. And secondly, a point that we're beginning to appreciate more and more is that, with a few exceptions, patients that harbor actionable biomarkers have a lower response to single-agent immune checkpoint inhibitor therapy. So this chart really shows the best overall response rate for patients with multiple different modes of therapy based by biomarker status. And what you can see is the responses to targeted therapies, to immune checkpoint inhibitors, and to some combination of therapies. And what you can really notice is that, for most of these actionable biomarkers, the response rates to single-agent immune checkpoint inhibitors is quite low compared to targeted therapy. In addition, the dual agents show some immune-related toxicities. Right now, EGFR and ALK are predicted negative biomarkers for immune checkpoint inhibitors, are in labels exclusion criteria, and even guidelines are starting to note that broader testing should be done before deciding on using immune checkpoint inhibitors for patients with non-small cell lung cancer. So additional data came from a real-world analysis presented at ASCO this year. And so this was a study out of 13 community oncology practices here in the United States, and looked at patients who harbored actionable oncogenic biomarkers and who either in group A were treated before the report was issued, or after the report is issued, excuse me. In group B, they were treated before the report, but then quickly switched to the appropriate therapy within 35 days. And then in group C, these patients were treated before the report, and they weren't switched to the appropriate therapy. So what you can see in the table here is that the outcomes, either apparent survival or time to next treatment, were significantly compromised in patients that harbored an actionable oncogenic driver and were either switched quickly or never switched to the appropriate tyrosine kinase inhibitor. And so this really shows that getting those results back prior to treatment is critical to maximize the outcomes for patients with non-small cell lung cancer. So how are we doing? And how is this being reflected in community practices? So this was an analysis of a large community network that looked at their contemporary clinical practice patterns and their use of genomic testing across their different practices in the United States. And what they found was, through their retrospective chart review, they found that less than 50, and they were only looking in this study at 5 biomarkers. So what they found was less than 50% of patients had received tests for all 5 biomarkers. So patients weren't receiving the optimal biomarker testing. The turnaround time was about 2 weeks. The minimum time to first-line therapy was 5 weeks. This raised a lot of anxiety for their patients waiting to have a treatment decision made. So the turnaround time wasn't quite where it needed to be. Only 35% of patients had results for all 5 biomarkers before first-line therapy. And so once again, the patients weren't having, and the clinicians weren't having the results back prior to making that treatment decision. So even though next-generation sequencing results increased over time, it still remained before 50%. So there's barriers that need to be addressed for non-small cell lung cancer. And what we're finding is it's really a balancing act, right? You need to have, the tests and approaches need to be comprehensive. There's now over 10 biomarkers that need to be interrogated, including PD-L1 immunohistochemistry. And the turnaround time needs to be there. This includes getting the tissue, diagnosis, getting the next generation sequencing results, and the PD-L1 immunohistochemistry. So how do we couple the different available technologies to maximize the turnaround time, or minimize the turnaround time, maximize the results? And so what I'm going to present now is a few real-world studies that have come out that show how these two testing modalities are being utilized in both community and academic practices. And the first study I'm going to present is a prospective study that looked at patients being treated in a U.S. oncology network, and we're looking at the additive value of tissue and liquid-based testing. And so these patients were enrolled on the trial, were treatment naive, and they were offered liquid biopsy, and they could also have comprehensive genomic profiling or other tissue-based testing as a complementary test. But they were enrolled based on liquid biopsy testing. And so in this specific study, they then compared the additive value of liquid to tissue testing, and then what could tissue add to liquid. And so I think if we look at the top, there's a few different cohorts: the patients that received tissue CGP in addition to liquid CGP, patients that had up to 5 genes tested, and then patients who had no tissue available. And so if we focus on these 2 cohorts here, what you can see, and so in red and orange is the tissue only, and in purple is the liquid only result. And so what you can see is that in patients who had limited tissue testing or no tissue, liquid biopsy increased the number of patients found to have a positive actionable biomarker, and these were NCCN guideline recommended genes. The interesting case, which shows the sensitivity of tissue, is that liquid biopsy didn't add much when tissue CGP was performed. This study didn't really look at turnaround time, but basically it was showing that in instances where tissue is insufficient or in limited tissue testing, liquid biopsy can add to tissue-based testing, showing the complementary nature of these 2 different biomarker testing approaches. So another test corroborated another study in an academic center corroborated these test results. And they showed that integration of tissue CGP or liquid CGP into the routine management of non-small cell lung cancer increased the detection of actionable biomarkers. So what you can see here is that 29% of cases, there was actually a preference for liquid biopsy. 31% of cases, no tissue biopsy was available, and then in 40% of cases, they had tissue and liquid testing. And what they found was that adding liquid biopsy in increased the detection of actionable biomarkers for these patients. And not only that, patients who were found to have an actionable biomarker with liquid biopsy and went on therapy had a response. So this improved the delivery of a targeted therapy approach in a real-world clinical setting. And so what about looking at turnaround time and even in the dream world survival? So this was a real-world study that was presented also at ASCO this year that looked at the association between concurrent tissue and liquid CGP and overall survival in non-small cell lung cancer. So these patients had metastatic non-small cell lung cancer. They went 98.5% underwent some form of molecular testing. 1/3 had tissue CGP. 2/3 had tissue and liquid CGP. So of those patients who underwent molecular testing, 88% had comprehensive testing, defined as having a result for all of the biomarkers in guidelines. 12% had incomplete testing. And what they found was that patients who had concurrent tissue and liquid testing, CGP this was, had more likelihood of comprehensive testing. So more comprehensive testing was performed when tissue and liquid were done concurrently. And additionally, they added on to this and found that patients with comprehensive testing had a superior overall survival versus those with incomplete or no testing. And this was likely due to the delivery of targeted therapy. So not only does adding liquid biopsy in increase the percentage of patients with comprehensive testing, which is critical in non-small cell lung cancer, in this study they found that it improved survival. And additionally, they found that the results were back prior to first-line therapy, which was important, is very important for patients with non-small cell lung cancer. So this was great data presented in the community academic center, but what about in the community? So we partnered with a large community practice and did a retrospective chart review of their practice patterns and presented it at ESMO this year. And what we found is that in this large community practice, 42% of patients with non-small cell lung cancer had tissue and liquid testing for their standard of care workup. Only 40% had tissue only, and 16% had liquid only. The turnaround time, as expected, was much faster for liquid biopsies. And interestingly, what we found was the timing of test results was much faster. Patients had tests ordered and received pre-treatment more often when they had liquid and tissue testing than when they had either other modality alone. So using both tissue and liquid resulted in having the result in hand before making that treatment decision. So this was a really interesting finding that we found in this large community practice. So taken together, what is becoming apparent is that liquid and tissue testing are complementary in advanced non-small cell lung cancer. We understand that comprehensive profiling is needed prior to first-line therapy. You also need PD-L1 immunohistochemistry. These results need to be back pretty quick. The turnaround time is paramount in this disease. And so upfront liquid and tissue testing is becoming more and more critical for these patients who you have small biopsies, you need to get a lot of genomic information. So both types of testings are complementary to each other. So in the recent consensus from the ISSLC, they proposed a few different diagnostic algorithms for patients with treatment-naive advanced non-small cell lung cancer. And so for a patient that's newly diagnosed with advanced non-small cell lung cancer, If tissue is unavailable for tumor biomarker testing, they recommend a plasma-first approach. Use liquid biopsy, and if you get an actionable alteration, you can act on it due to the high PPV of a liquid biopsy result. However, they also emphasize that if a tissue is or liquid is negative, to do a rebiopsy for tumor tissue to confirm that negative result. And so this is a critical point, I think, that needs to be emphasized. If tissue is available, there's a few different approaches that can take to integrate these two testing modalities. One, you can send for tissue testing, see if you get a result, and if it's incomplete, perform liquid biopsy. The question there is, what is the turnaround time, and how long do you have to wait for that negative result? Do you have an in-house assay with a little bit faster turnaround time that you can know a little bit quicker that you have a negative result, and then you can reflex to liquid biopsy? Do you have, or in instances where you know up front that it's a really small specimen, you're probably not going to get information for all of those biomarkers. Maybe using a concurrent tissue and liquid approach is best in those instances. So it really comes down to a lot of different factors, how to integrate this testing. But I think as more of this real-world data emerges and the more we're seeing the utility in both academic and community practices, we're seeing ways that this is benefiting patients and maximizing their outcomes, and especially in a disease such as advanced lung cancer, where the outcomes are quite poor. So just to summarize, comprehensive genomic profiling for NTRK fusions and RET fusions, emerging data for NRG1 fusions. It's becoming increasingly important to get that RNA analyte for detecting fusions. You can interrogate either tumor tissue and ctDNA. In instances where tissue is insufficient, you can reflex to liquid biopsy to make sure you're getting biomarker information for either targeted therapy selection or for clinical trial inclusion. In cases like non-small cell lung cancer, there's options to use both up front or to use them sequentially, or in instances where there's no tissue, you can do a plasma-first approach. You can get pan-cancer information. There's now 5 FDA-approved tumor-agnostic biomarkers, so making sure that patients are tested for these biomarkers is becoming increasingly important. And so you're really maximizing the ability to identify different actionable biomarkers. And with that, I will thank you for your attendance and your compliance, and I will be happy to take any questions.
Any questions? Please raise your hand.
So I was wondering about that study you did with the, in the community group where there were people were tending to get the results more quickly when you did both concurrent liquid and tissue. Was it because the physicians waited for the results, or were the results just delivered faster?
So when in that specific study, the results with the liquid biopsy were there faster. The physicians were able to make a decision faster. And so that was just looking at when did the results come and when was treatment selected. So since they incorporated liquid biopsy, the results came back pretty much quicker than just using tissue alone. But that's a great question to tease out those 2 points.
Anybody else?
Thank you for this great talk. So I have a question regarding like the slide you showed detection rate across different type of tumors. There was like 4 samples in thyroid. I wonder what was the tissue or like pathology type. Papillary thyroid carcinoma more likely to spread by lymphatics, while follicular more by blood. I wonder if this will have an impact on the detection rate.
So can you clarify your question? I'm sorry, you were coming in and out, yeah.
Sorry. So for the thyroid, you had 4 samples.
Yeah.
So what was the pathology? Was it papillary thyroid carcinoma or follicular? Follicular more likely to spread by blood, but papillary is more likely to spread by lymphatic. What was the pathology? It will really give better understanding about the detection rate.
Yeah, that's a great question. And so in that study, they didn't disclose what it was. They just had them lumped together. But that's a great point. And hopefully future, there's other studies or future studies that could look into that for thyroid cancer, because there is a high frequency of NTRK fusions and RET fusions. So I think that's a place where it's really important to see when and where liquid biopsy might be best applied.
Okay, sounds good. Thank you.
Yeah.
Really quick question. Good talk. Thank you. I may have missed that, but for all these studies, was that the same library or the same kit, the same mutation panel that was used?
That's a great point.
And how many mutations were in that panel or that kit?
So for the, I could speak directly to the last study in the community setting. So they used multiple different commercial CGP panels. We compared, when we did different analyses looking at concordance, we compared what genes were similar between the panels. I think for some of the other studies, they were looking at NCCN genes. For the CGP test, they all covered those. The one test was from a commercial vendor, and they used the same test from the commercial vendor, which had the same bait set. So I think that was the case that it was the same bait set. But I think for making the point, looking at the concordance or complementary nature, it's important to take that point into effect and making sure you're looking at, assays that have the same coverage of the genes. Yeah.
Hi, great talk. Can you comment around the reimbursement model for this? I think from a clinical point of view, it's fantastic, but what does it look like from the landscape and reimbursement?
Yeah, that's a great question. And I think what we're seeing is that multiple different community and academic practices are making this work from a reimbursement perspective. I think what we need to do concertedly is bring this type of evidence to payers to make sure it's covered for all patients. But I think specifically there are ways that different groups are getting these both tests covered, especially in non-small cell lung cancer.
Yeah, I have a question here. Yeah, so the concurrent approach, of course, is that in theory it's the best approach, but I'm just wondering what if you get inconsistent results in between, for example, blood TMB versus TMB itself is still kind of like not really standardized in a way, and due to tumor heterogeneity, you might find mutations in the liquid sample, but you did not find in the tissue. So I wonder that when you do the concurrent approach, then you get inconsistent results in between, and how do they make a choice?
Yeah, I think that's a great point. I think that looking at, there's different factors and things didn't talk about was like timing between specimens, treatment in between, looking at the different test results. And so I think blood TMB and TMB is a unique scenario, biomarker to think about. I think there's more data needed for blood TMB and its ability to be used as a predictive biomarker. I think there should be a standardization. There is a standardization for TMB itself, but I'm sure there's going to emerge for BTMB when we get more clinical evidence for that specific biomarker. I don't think we have the cutoffs yet or anything to establish that as a bona fide predictive biomarker.
So as far as reimbursement is concerned, you know that it would be helpful if it was an IVD assay. So I was wondering when the TSO 500 becomes IVD. We've been waiting for a while.
Yeah, that's a great point, and it does impact reimbursement.
Okay. Well, thank you for attending this workshop. Please stay around. There is another workshop on the tissue component of CGP testing coming up. I've got some food also, but we'll be back shortly at noon.